Hello, friends. Can you see me? Hi, good evening. I know it's not a good time to take class, but what to do? This is the time I got free, and I thought I'll take a small session on study designs. And if you have any, I mean, I hope you guys are there. I can see many, but no chats yet, just one chat. Are you guys ready? May I start? Okay, I hope you're all in a good mood to study. You have been studying community medicine or PSM because in many universities, it is a final professional exam, which is happening right now. So, study design, as per my knowledge, is the most difficult topic for you guys because, all others, in all the other things, you will get a straightforward answer. Like, you don't have to guess anything. Like, there will be a short note and you just need to write the answer to that short note. Whereas in study design, mostly this you will get as an essay, right? And there will be some sub questions. Like, a study was done to know the relationship between smoking and lung cancer, or myocardial infarction and maybe diet or something. Okay. And they want to know what are the risk factors of one particular disease. Okay, something like that. Or a group of pregnant ladies were followed up to know the outcome. So, such questions will be there, and there will be some sub questions. Identify the study design. What are the outcome measures? What are the steps in conducting the study design? How will you interpret the result? Right? So, such questions will be there, and it is usually difficult for you guys to identify or to differentiate. So I thought we will discuss the main study designs. Okay. Hi, Blessy. Hi, Venkat. Okay. If you guys are ready, I'm also ready. So first, let me tell you what is study design. We will not be discussing everything because I have only 15 minutes, and 15 minutes it is not possible to discuss everything about study design, but only the important study designs. Okay. So study design means what you need to understand is, as the name indicates, it is a design for doing study. See, merely collecting data from the patients will not make it a study or a research unless you follow certain guidelines and scientific guidelines regarding, how to do the study, how to analyze the outcome. All these are based on various study designs. Okay. You should be familiar with how the study designs are classified because this itself is a short note. The classification of study design is a short note. You know, the study designs are mainly divided into observational, experimental. Broadly divided, I would say, into observational, experimental. Observational means, so many things are happening around you. You're simply observing and doing the study. That is observational. Whereas experimental means, as it is said in the name, you're experimenting. That means you're doing some intervention and you're seeing what is the outcome following that intervention. Like you are giving a new vaccine and you're seeing what percentage got cured or what percentage of diseases you could prevent. You're giving a new drug and you're seeing what is the outcome or how much or what percentage or what proportion got cured. So experimental, right? Under which you have mainly RCT, but usually RCTs are not asked for your exam. Then observational is again divided into descriptive and analytical. Descriptive means, as the name indicates, you're observing, you're simply describing it as such. Okay, like, how many were having disease and what percentage were males, what percentage were females, like that you are simply describing. That is descriptive. Under which the one important for your exam is cross-sectional study. Analytical means you're going one more step further where you're trying to find out the association between, you're trying to find out what is the association between an exposure and outcome. Like I said, smoking and lung cancer. What is the relation between smoking and lung cancer? What is the relationship between X-ray exposure and papillary CA, thyroid? So you are trying to find out what is the association between one particular exposure and outcome, under which you have case control and cohort. Now, let me tell you guys, the ones important for your exam are mainly the cross-sectional study, case control study, and cohort study. Okay, so this is how the study designs are classified. I hope it is clear. Now, let's see, or let's start with the one which is always confusing, the analytical study designs, under which you have case control and cohort. And we have already seen that in analytical study design, whether it is case control or cohort, you will always find two different things. Which are they? One is there is an exposure, then there is an outcome, and you want to know what is the association between exposure and outcome. So there is an easy way to remember, analytical study design to find out association, A and A. Okay, so association between the exposure and outcome, under which you have case control and cohort. So my question is, see, in both case control and cohort, you have exposure and outcome, right? And both you are using to find out the association. Then what is the difference? What is the difference between these two study designs? The difference is the direction in which you start the study, from where exactly you are starting the study. In case control, as the name indicates, cases means a group having disease. Control means a group without that particular disease. So you are starting with deceased and non-deceased, and then you are retrospectively assessing their previous exposure. Now, what is cohort? Cohort means, what is the word meaning? It's a group having something common. Okay, common what? Exposure. You're starting with a group of exposed. You are starting with a group of non-exposed. That means exposed, non-exposed. You are prospectively following them to see what percentage in the exposed and non-exposed have developed the outcome at the end of your follow-up time. That is what you do in cohort. Okay, so that is a basic difference between case control and cohort. Okay, so guys, you have an exposure, outcome in both. In case control, you are starting with outcome. Okay, you have deceased, non-deceased. Then you are retrospectively assessing their exposure. Like, you have a group of carcinoma lung patients, group without CA lung. You are asking about their smoking history, and you're trying to find out what percentage of your lung cancer patients were smokers and what percentage of your group without lung cancer, that means controls, were smokers. And this difference in the exposure is what you are comparing in a case control. Whereas in a cohort, you are starting with the exposed and non-exposed. Okay, so in cohort, you have the exposed group, you have the non-exposed group, and you are following them into the future to know what percentage have developed disease or some outcome at the end of your follow-up time in both. And this difference in the outcome is what you are comparing in a cohort. Okay, so if you're getting a question, first thing that you have to do is see from where exactly the study is starting. Okay, so that will help you to know whether it is a case control or cohort. And one more thing, in case control, usually you will find certain, certain key points to identify, like history, taking the history, or retrospective. So such key terms will help you to identify whether it is case control or not. Whereas in cohort, you will find looking into the future, prospective, then follow up, looking at the outcome. So these key terms will help you to identify whether it is a cohort or not. Okay, so that way you can identify. So case control, like I said, you're starting with, suppose you're asked to write why it is a case control, then cases, group of subjects with a particular disease. You're starting with controls, then disease has already occurred, and measuring the exposure status is what you're doing in case control. So the question will be, why it is case control? The answer is what I have shown here, like this. Okay, starting with group of cancer patients, taking the history, and you are comparing the history is what you are, that means percentage of exposure is what you do in case control. Let me see whether, hi Nia, hi Tino, hi Kishore, good evening guys. Now moving further. In case control, What are the steps in doing case control? This is something that you will get for the exam. Anyway, I will not be going into the details. The first is you have to select cases and controls, right? Diseased and non-diseased. Then you have to do matching. I'm not in a position to say what is matching right now. Just understand that you're matching the cases with controls in terms of certain variables like, age, then their gender, sometimes, some exposure, family history, something you are matching. Okay. Then you are measuring the exposure, how much is the percentage of exposure, and finally you are doing the analysis and interpretation. So to remember this, shall I give you a mnemonic? Look at this, guys. You will find a mnemonic here. Sorry. The glitches keep happening. What to do? Okay. Okay. So the mnemonic is, you can remember, SMART. Smart. So case control is a smart study design. Are you able to relate? S is here. M. A. Okay. Smart. So that way you can remember the steps. I don't have time to repeat, but you have understood, I guess. And what is the final analysis? Final analysis is in the form of odds ratio, right? You have heard about odds ratio. You know what is ratio? There is a numerator and denominator, and numerator is not a part of denominator. Now, what is odds? Odds is something which is again familiar, something that we normally use. You know, what is the odds of getting head when you are tossing a coin? What is the odds of getting 6 when you are tossing a die, right? So it is probability. So naturally, in calculating odds ratio, you are looking at the probability of disease among the exposed divided by probability of disease among the non-exposed. Okay, so just understand that is what you are doing. And in a 2 into 2 table, I don't have time to explain 2 into 2 table. What you see here is the 2 into 2 table. Just understand that there are 2 columns and 2 rows. And remember this CD when you are constructing 2 into 2 table. C is column. I would like to ask you what it is, but no time. D is disease. Are you getting me? That means in the column, you always write disease status. Okay, if it is CA lung, CA lung, then controls here. Without CA lung, then here the exposure will be smoking. Something like that. Okay, and these will be certain numbers. And odds ratio is given by the formula AD by BC, right? Odds ratio is AD by BC. Okay, and look at the odds ratio. If there are some numbers here, like, okay, I'm just going to put some numbers, like, there are 100 CA lung patients, 100 normal people. When you asked about the history, you found that out of these 100 CA patients, say, I'm just going to put some numbers, 60 were smokers, and out of this 100 controls, say, 20 were smokers. Okay, so I'm going to put 40 here, 80 here. Am I right, guys? Okay, so this is how you construct your 2 into 2 table. And let it be any number. It is A, B, C, D is what I meant. Okay, so here what will be the odds ratio, guys? Odds ratio equal to 60 into 80, AD by BC, right? Divided by 40 into 20. So you will get it as 6, right? Hana, 6. Now, what do you mean by odds ratio of 6? Odds ratio of 6 means smokers have 6 times more chance for getting lung cancer compared to non-smokers. So this is how you do the interpretation. So the final interpretation would be, let me just go back and show you. If odds ratio is more than 1, that means this exposure is a risk factor. If odds ratio is less than 1, this exposure is a protective factor. When will you get such a relation? Guys, if you're knowing the relation, if you're trying to find out the association between vaccination and a disease, like, measles vaccine and getting measles, naturally, the probability of getting disease will be less among the vaccinated, right? Right. So it will be the opposite. and you will get odds ratio less than 1. I would love to explain, but the thing is I don't have time. So let's quickly go through the important points along. So if odds ratio is less than 1, that means exposure is a protective factor. And if odds ratio is equal to 1, that means there is no association between this particular disease and the outcome. Okay, or sorry, exposure and the outcome. So that is about case control. And what about cohort? I said you're starting with the exposed, non-exposed, right? You're starting with a group with a particular exposure. Then you need a control to compare a group without that particular exposure. And only exposure has happened there. You are following them for a particular period of time to know what percentage of your exposed will develop outcome at the end of your follow-up time and what percentage of your non-exposed will develop outcome at the end of your follow-up time. Okay. And here the study is beginning with exposed and non-exposed like this. Okay. I think I don't have to tell you. Like I said, you will find some key points like followed up, into the future, prospective study design, such things you will find there. Okay. Hi, Anza. Now coming to next question will be, what are the steps in doing cohort? The other one was SMART, right? Here there are many steps. Selection of study subjects. First, you have to select the study subjects, right? Then obtain the data on exposure. Okay, you take the, if we take the case of smoking and lung cancer again, you are first taking a group of smokers. Okay, then you obtain the data on exposure, then select the comparison group, then you do the follow-up, and then you do the analysis. Okay, so here there are 5 steps and you can remember it using a mnemonic. It's a prayer. Okay, it's a prayer. Cohort is something which will take a long time, right? You are following them for, suppose you're studying a rare outcome, just imagine how long you have to wait, right? You may have to wait for 10, 20 years for that outcome to happen, right? So remember, it's something which is taking a long time. So you are praying. What is it? Save our souls, Father. Okay, to the, the Almighty. I just try to give you some mnemonic so that you will be able to remember at least this. So, save our souls, Father. So remember like that. So that is the step in doing a cohort. Now coming to the outcome measures in a cohort. I will not be going into the details. Just understand that there are 4 outcome measures in a cohort. One is incidence. Incidence means new cases, number of new cases which are happening in the exposed at the end of your follow-up time, and the number of new cases which happened, or, new outcomes which happened in your non-exposed at the end of your follow-up time. That is incidence. Then you have relative risk. Then you have attributable risk, and then you have population attributable risk. And this also you can remember, since there are 4 outcomes, you can use this mnemonic PAIR. What is it? Pair. 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 Okay. So that is, these are the 4 outcome measures. I think I'm running out of time, but it's okay. Am I clear? And the interpretation of relative risk is same as that of odds ratio. Odds ratio, if more than 1, that will tell you whether the exposure is a risk factor or not, right? Similarly, the cohort will also give you in cohort, relative risk will also give you the same interpretation. Okay? Or else I'll do one thing. I'll just try to draw a 2-into-2 table just for your understanding. Are you seeing a table? Okay. So I'm doing a cohort study to find out the relationship between smoking and lung cancer. Again, okay. So I said along the column, you should always write disease status, right? Then smoking here. So CA lung plus, minus, smoking plus, minus. From where am I starting this time? I'm starting from the smokers, right? I have 100 smokers, I have 100 non-smokers. Are you understanding? And I'm following them for say 10 years to know what percentage of smokers will develop lung cancer at the end of 10 years and what percentage of non-smokers will develop lung cancer at the end of 10 years. Okay, so when I did it, just imagine that in the question it is given that out of 100 smokers, say 10 develop lung cancer at the end of your follow-up time, and out of 100 non-smokers, 2 develop lung cancer at the end of your follow-up time. So what can I write here? Here I can write 90, here I can write 98. Hope you're with me. Okay, let it be any number. It will be A, B, C, D, right? First, what is incidence? Usually incidence and relative risk is what you get for the exam. Incidence of disease among the exposed will be 10 by 100, is it not? Out of 100, number of new cases. Incidence is number of new cases. That means number of new cases of lung cancer which happened among the exposed at the end of your follow-up time. So that is 10 by 100. Then incidence of disease among the non-exposed will be, come on, tell me guys. Odds is not considered here because, see, I'm not going into the details. Odds is not as good as relative risk because there are, when you do a case control study, see, Sajal is asking why are we not doing odds here? See, odds is something that you get from a case control study. In case control study, there are a lot of bias. You might have learned, or at least you might have heard about this, that there are some bias, lot of bias in case control, like, interviewer bias, then recall bias. Guys, this is something which is based on recall, right? If I'm asking you what you had 2 weeks back, will you be remembering how many cigarettes you had years back is something that you are asking. I'm not exactly about cigarettes. What I'm saying is, you are asking about something which happened in the past. And how can you expect the people to remember all this? And sometimes those with the outcome will be remembering it more. Do you agree with me? Whereas those who do not have the outcome, like, controls will not be remembering it. Like, if you're asking diabetic patients what they had last week, how many laddus they had, definitely they will remember. Whereas if you're asking the same question to a person without diabetes, definitely he won't be remembering all that, right? That means the recall bias will be there because the people who are cases will be remembering about their exposure more. Right. So I'm not going into those details. Then interviewer bias, because suppose I am the person who is interviewing the patients. I will have a tendency to probe more into the history of those who have the disease, right? Suppose I'm asking CA lung patients, how many, suppose, just imagine that there is a CA lung patient. I'm asking, have you ever smoked? Then this person may say, no, I haven't. Then I'll be like, I'm not happy. I'll be like, are you sure you haven't smoked at all? At least, when you were studying in your college, just remember and see, at least one puff you might have taken. Then he may say, I forgot I had it when I was, then I will brand him as a smoker. Whereas same question I'll ask to another person who is a control, then if he's saying no, then I'll be happily writing there, okay, he is not exposed. Are you understanding? So, that is something which can happen from the interviewer end. So, but lots of bias will be there. So, the odds ratio is not a good measure compared to relative risk. Actually, I had no intention to say all this due to lack of time. Anyway, please do understand that we are not using odds ratio here because odds ratio is easy to get. Whereas incidence is what is exactly going to give you the outcome. Because when you started the study, none of them had the outcome, right? And you're very sure that all these happened. There is something known as temporality. Temporality. Have you heard about, oh my God, Hill's criteria of causal association? Hill's criteria of causal association. It is there in your park. There, the most important factor which will tell you whether the outcome is because of the exposure is temporality. Now, what do you mean by temporality? Means relation in time. That means the risk factor came first, followed by the outcome. Okay, which you will not be able to capture in a case control, right? You're asking them about the smoking. How can you be so sure that the disease started after they started smoking? Sometimes it would have been the other way around, right? Whereas when it comes to cohort, you're damn sure that when they started smoking, none of them had the outcome. And the outcome happened after they started smoking. That means temporality is well established there. Okay, so cohort is a better study design. That is what I am trying to tell you. So the incidence is something which is going to give you a robust outcome. Okay, so forget about all that. Here the incidence will be non-exposed. 2 by 100. I hope the person who asked the question, Sajal, you might have got some idea about what I am trying to tell you. Okay, so that is incidence. Then you have relative risk. Only incidence and relative risk is what you usually get for the exam. Relative risk means in relation to the non-exposed, how many times more is a chance for exposed to develop the disease. Okay, so you already know the incidence among the exposed. You already know the incidence among the non-exposed. Divide it. That will give you the relative risk. So what is relative risk? Relative risk is incidence among the exposed divided by incidence among the non-exposed. So how much will you get? See, already you know. Tuck, tuck, cancel ho gaya. So you will get 5 here, right? So relative risk is 5. Now what do you mean by relative risk of 5? I said the interpretation is same as that of odds ratio. Means these smokers have 6 times more, sorry, not 6, here it is 5, right? 5 times more chance for developing lung cancer compared to the non-smokers. Okay. So that is how you interpret incidence and relative risk. And attributable risk, population attributable risk, usually they don't ask. Just understand that these are something to do with prevention. That means if you remove this exposure, what percentage of risk you can reduce is something that is given by attributable risk and population attributable risk. I don't have time to go to those details. This is with the prevention. What percentage of disease can be prevented once you are removing that exposure is what you are getting out of 3rd and 4th. Okay. Next is cross-section study. I'll be discussing only these 3. Cross-section means, of course, as the name indicates, you're taking cross-section of a population. That means at one time, you are taking the cross-section of the population, like doing a survey. Doing a survey is the best example for doing cross-section study. So in the question, if you find this term, they did a survey, do understand the question is about cross-sectional. Okay. Or they describe, they took a group of patients, they found that, they took they took 100 corona patients or COVID patients, and then they explained, they found that majority were males, only 20% were female, something like that. If they are saying, please to understand, it is a survey. Okay. Simply explaining. And here, as the name indicates, when you do a cross-section using a survey in a community, for example, today is 13th of December, right? Suppose I want to just imagine that I am staying in a city named X. Okay, I am residing in a city named X, and I want to know, I'm doing a survey to find out how many COVID patients are there in my city. Imagine that I did a survey in 10,000 people. Today, using with the help of my PGs and undergraduates, I did a survey in 10,000 houses, and I found that out of this 10,000, today, simply I'm putting a number, okay, 100 were having COVID. Okay, that means if I multiply that with 1,000, this is getting cut. That means 10 per 1,000 were having COVID on or as of December 13th. Okay, so this is what you get out of a survey. Or this is nothing but, this is what you call as prevalence. Have you heard about prevalence? Don't say we haven't heard. You know what is prevalence. Okay, prevalence means at one point you are trying to see how many are having a particular disease. Okay, so that is exactly what you do in a cross-section study. Am I clear? So if you see the term survey or you describe the population, then or prevalence, which is the study design to find out the prevalence, the answer is cross-section study. Okay, now what is the advantage of doing cross-section study? Cross-section means at one time, it is one-time examination. It is one time, where to write? Okay, I'll write here. It is one-time examination of a population. One-time examination of a population. Okay, so it is like taking a snapshot of a population. Okay, and what is the advantage? Suppose when you did a survey today, and like I said, I found that 100 were having COVID. I can very well explain everything about these 100 COVID patients, right? Out of this 100, how many were males, how many were females, then, how many were having complications, how many were hospitalized, how many were okay, everything, right? So that is the advantage of doing a cross-section study. You can very well explain everything, but it will not give you the association. If you want to find out the association, let me just go back and tell you. Simply, where was it? I told you to find out the association, you have case control and cohort, whereas just to describe, you have cross-sectional. Haven't I told you? So that is what I meant by saying that when you do a cross-section, you will get the number of disease people and you can very well explain everything. You can describe everything about those patients at that point where you saw them. Okay, so this is exactly like, when you take a cross-section of an apple, suppose you found a small lesion here. You can relate this lesion to the disease, COVID, that you found at that point where you took the cross-section. You can very well explain everything about the lesion at that point, right? The size, the shape, the vicinity, all those things, right? But you can never say what was happening to the lesion beneath or beyond unless you take one more cross-section, right? Okay, so the advantage of cross-section study is you can explain everything about that disease at that point. But you can never say what was happening to the disease till yesterday or what is going to happen to the disease tomorrow or in the future unless you take one more cross-section. Are you with me? Okay, I would love to explain, but no time. If you have any doubt, you can ask me later. I have given you my number. Didn't I give you my number? Somewhere I'm so sorry. I'll give you my number. See, this is my WhatsApp number. If you have any doubt, you can ask me. Okay? Later. And this is my Instagram ID. I will be posting short reels. It's an academic page where I'll be posting short notes and all those things which are important for your exam. Okay. So what was I saying? Yeah. So this is about cross-section study. Next. What are the steps in doing descriptive study design? Okay. One is defining the population to be studied. Then defining the disease under study. Then describing the disease. First, you have to define the population to be studied. Okay, which is the population that you're studying. Like I said, city X, people in city X. Defining the disease. Which is the disease? COVID. Then you describe the disease. After taking the COVID or after taking those 100 patients, you describe them in terms of time, place, and person. Not going into those details. Like I said, how many are males, how many are females, where they were residing. Then you measure the disease, okay, in terms of numbers. Then compare it with the non-indices and then you formulate an etiological hypothesis. You can remember this mnemonic. Doctors do daily medical checkup frequently. See, doctors do daily medical checkups frequently. Are you seeing? So this way you can remember the steps in a descriptive study. Okay. So guys, in short, what I want to tell you is we have discussed 3 study designs: case control, cohort, cross-sectional, right? Both these are to know the association between the exposure and outcome. Okay. The difference is the relation. Okay. And if the direction is from today to back, retrospective, it is case control. Okay. So case control is something which can be done very easily. It will take a short time. Okay. And this is the one which is used to study rare diseases and also to find out the risk factors. So if you want to know, if you want to do, suppose there is a study done to find out the risk factors of something, then please do understand it is case control. Whereas cohort is prospective study design, right? So this is a disease to find out the outcomes. What are the outcomes? Okay. And since you are starting with the exposure, this is something which is done to study rare exposures. Rare exposures. So from where you are actually starting, you can study rare entity of that particular thing. That means nothing, guys. Case control, you're starting with disease, non-diseased, right? So that is something which is used to study rare diseases. Because for studying rare diseases, haven't I told you, cohort is not good. Because if it is a rare disease, you may have to wait for 20, 30 years for that disease to happen, right? So why don't you start the other way around? Start with all those rare cases, put them as cases, then you take a group of controls. Am I clear? Okay. Now, what is the use of, this is retrospective, this is prospective, whereas this is something which is happening today. That means at present, one-time examination. This is something which is done to know what is the present situation. Okay. So this will help you to formulate etiological hypothesis. Formulate etiology means, something which, what could be the reason? Okay, that means the probable risk factors that could have led to the disease. Formulate etiological hypothesis. For example, suppose you studied, say, a group of CA lung patients. Okay, imagine that you don't know anything about the etiology. You just found that 80% of them were having, 80% were smokers. When you simply described, you found that 80% were smokers, say 60% were having family history, and 40% were having exposure to asbestosis. Okay, when you simply describe, this is how you got. Then, as a, using your common sense, what will you suspect? You may feel that for this particular disease, smoking could be a risk factor. Family history could be a risk factor. Asbestos exposure could be a risk factor, right? So using this, you can make a hypothesis. That means for this particular disease, probable risk factors could be smoking, family history, and asbestos, right? Whereas in case control and cohort, these are analytical study design where you are trying to find out the association between exposure and outcome. That means you want to know whether smoking is a real risk factor or not. So I'm going to write the next point, guys. These two are analytical study designs where you are testing the hypothesis. So hypothesis, by the way, what do you mean by hypothesis? Hypothesis means it is a, it is an observation that you got, which is not yet proved. It's an assumption based on your observation, which is not yet proved. And you're trying to prove whether this probable risk factor is real or not by testing the hypothesis. So if in the question, if you're seeing, okay, the doctor found that there is some relationship between COVID and diabetes mellitus, and he wants to test the hypothesis, then the study designs that you have to go for would be case control and cohort. Okay, so for formulating etiology hypothesis, you do cross-section study. And I hope you have got an idea about the major study designs, which are 3 in number. Okay, so the outcome in case control is odds ratio, cohort, pair, right? Whereas in cross-section, it is prevalence. Okay, guys. So we have discussed a lot about 3 important study designs, and I hope it was useful. Was it useful, guys? Was it useful? I think there is a lag between what I am saying and you hearing me is taking some time. Okay, Harish. Okay, bye. Good night. It's already 10:40. So may I leave? If you have any doubt, you can you can WhatsApp me to this number, and please do follow this Insta page if you are interested, because I will be posting such mnemonics and steps, then small reels to help you to study community medicine. Okay, so bye guys. I've already taken more than what I was permitted to do, because you were asking me a lot of doubts. Okay, so let's call it a day. Good night. All the best for your exam. See you. Bye.
Recording stopped.